Thank you, Eric. Thank you, Ted, for the invitation to come and speak. I will say that this was a little bit more of a difficult talk for me to put together than I'm used to, only because there's not a lot of data out there on training from a GI point of view, training surgical residents. And so I'm going to go through some of the things that Dr. Mellinger's also spoken of. Probably there's going to be some overlap. And then I'm going to kind of give you an idea of some of the things we've done from GI just to help kind of train surgical residents. I have no disclosures. So just to give you my background, I'm a therapeutic endoscopy attending. I'm a member of ACGME. I'm a member of SAGES. I'm on the flexible endoscopy committee. When I was at WashU on faculty, I helped train not only the surgical residents, but also helped train some of the MIS fellows. And then currently I'm at Northshore University Health System, and I'm actually helping kind of strengthen the training opportunities for the surgical residents. So why do we need to train surgical residents flexible endoscopy? Well, partly because of the mandates by the American Board of Surgery. And honestly, I feel like it allows for better collaboration between GI and surgery. We know that more surgeons are going to be doing flexible endoscopy, and it's going to be a bigger part of their practice. And we also know, obviously, that it's less invasive than surgery. It can greatly benefit patient care. And honestly, for me, I would much rather have a well-trained surgeon in flexible endoscopy than not a well-trained surgeon. I just think it's going to benefit patient care. We know that more than 50% of practicing surgeons depend on EGD and colonoscopies as part of their practice. Many communities in the United States and Canada rely on general surgeons to provide access to endoscopic procedures. And obviously the RRC and the ACGME recently increased residency training requirements for flexible endoscopy. But despite all these accreditation emphasis, resident exposure to flexible endoscopy really remains erratic, and we're trying to make some steps towards achieving a better experience for them, including GI simulators, validated and standardized endoscopy curriculum through ASGE and SAGES, and trying to get better structured experiences with either rural surgeons or other high-volume endoscopy centers. So the 2017-2018 academic year surgery resident graduates must complete 85 total gastrointestinal endoscopy cases, so 35 EGDs, 50 colonoscopies. And this is basically what Dr. Mellinger was talking about. There's actually, and this is one of the things we've been talking about in our flexible endoscopy committee, is there is a big difference between what you see ACGME for their minimum requirements, ASGE, and SAGES is very similar to ACGME. But really, when you look at colonoscopy, 50 for ACGME is the requirement, whereas ASGE is saying 140, and then EGD is 35 for ACGME and 130 for ASGE. This is, to me, a much bigger discussion, and as we talk about competency, like over this talk. But obviously, there's been a lot of discussions just in the committee meetings about these numbers, and obviously you heard about how there's going to be a response based off of the newest ASG privileging and guidelines for training that just came out. So surgical endoscopy minimum requirements. So teaching a flexible endoscopy as general surgery lacks consistency and as such requires a formalized curriculum. It's part of the reason there have been big pushes to really get a more standardized curriculum for the residents. It's really variable and in volume adequate settings, and one crucial aspect of successful endoscopy training is clinical volume. We know that they can garner experience in flexible endoscopy during operative procedures. Unfortunately, for the most part, they can't actually log those cases because they're logging the cases for the laparoscopic surgery or colorectal surgery. General surgery and GI endoscopy rotations also help get experience for the residents. And obviously, there are other courses we have for them to give them extra exposure. According to the American Board of Surgery, and this is something Dr. Mellinger just talked about, rural general surgeons perform a greater variety of endoscopic procedures than urban surgeons. And I think part of that is probably due to the fact that rural surgeons see a wider variety of cases and they're more dependent on doing procedures because they don't have other GI colleagues there. In the urban setting, you're more likely to have a gastroenterologist or advanced therapeutic endoscopist there who will take up a lot of the volume. And we do know that endoscopy can contribute substantially to financial productivity, and that may be also part of the reason why other surgeons in the rural settings are also doing more cases. Just to kind of look at ACGME, and if we look at basically what we try to do, really a lot of this should be basically parallel for what we're doing for surgical residents. Our objectives basically are making sure that our trainees are going to do appropriately recommend endoscopic procedures, perform the procedure safely, interpret the endoscopic findings correctly, identify risk factors, understand the principles and quality measures and improvement. For our institutions, we really need to make sure that they take place within a context of global clinical training program and that they're actually recognized by ACGME or the AOA. So for our curriculum, we really want to make sure that they're getting competent in technical skills requiring the foundation of didactic learning. So we need to make sure they understand what the indications, contraindications, limitations are of the procedure, how to do safe analgesia and sedation. What are the alternatives to endoscopic cases? Make sure they understand informed consent and a critical assessment of scientific literature. These are all the same sort of things that you guys are teaching your residents. We need to make sure there's an endoscopy training director. So each program should have an expert endoscopist and teacher. We need to make sure we monitor their progress, and we do that for our trainees as well. We need to make sure we have available resources for them, such as textbooks, atlases, videos, and videos are really starting to become a bigger part of our teaching repertoire. And so we're doing a lot of this also in ACGME. And just to put a little plug in for SAGES, there's a big push to actually have a video endoscopy that we're actually uploading videos, and honestly, Eric has done a large part of this, is to make sure that cases are getting uploaded so we have a video atlas so that residents can actually go and find these things and have a better understanding of what we're looking at. We need to make sure that we're also reviewing the evaluation forms from the trainers and the trainees. I think one of the challenges for all of us is really making sure we have time and institutional financial support dedicated for teaching. And I think that's one of the things we struggle with, just because our practices have gotten so busy. And I'm going to talk about that in a second. We need our residents to really spend the time having hands-on training. One of the things that happens with a lot of the residents, and I can even speak on at WashU for our GI fellows, when the procedure volume is very high, and it's because you have a lot of cases coming up, depending on the strength of the endoscopist and how comfortable they are, our fellows may not even get that much scope time because the attending is actually doing the procedure. And I think that's also a little bit of a detriment to the training program, but as long as they're watching and paying attention, they should be able to learn some of the things that are happening. We really need good mentorship from our expert endoscopic trainers. And really what we do expect to see is a natural progression, going from basically principles of anatomy and scope manipulation. That's what we want to really be teaching in the beginning stages, to making sure that by the time that they've gone along, they should actually be able to perform entire procedures and potentially attempt therapeutic intervention. We talk about in ACGME standard procedures and advanced procedures, and so really the standard procedures are things that are commonly performed and readily available, like EGDs and colonoscopies. Most trainees can expect to master these procedures over a 3-year gastroenterology fellowship. But what about surgeons? What about the surgeons who only get a month of training? And are they actually having enough cases to really be competent to do these? I think this is another big discussion. Obviously, the amount of time and experience varies for everybody who's going through training. And competence in one procedure, and I think this is an important thing, does not equate to competence in another procedure. So if you're competent in EGD, it does not mean you're competent in a colonoscopy. And I will also say that we have such variability for our GI fellows. We have people who've gone through 3 years and still struggle to do endoscopic procedures well. And so I think that's also an important thing that you have to really highlight when you're training your residents or your fellows, is to really try to increase their basic knowledge and their skills to get them to a point where they become very self-sufficient. Our advanced procedures, just to highlight, are really more complex and technically demanding, higher level of complications, and we have gone away from just doing brief exposure, so a 3-month period or a 6-month period during a general GI fellowship, to actually being able to, for those patients, our trainees now need to actually do a full year of advanced training. So just brief exposure is no longer appropriate. We need to look at our trainee competence. So obviously, evaluation encompasses both cognitive and technical abilities. Trainee logbooks, that's sometimes very hard, depending if you have an EMR or not. For a lot of the programs I've been to have had an electronic medical record, so we can actually log the number of cases our trainees are doing, and we can see, are they hitting their thresholds? There have been few studies out on the rate of proficiency, and so if you look at Bob Sedlak from Mayo Clinic, he's done some of the studies, and they looked at basically what they think is a benchmark. And just as Dr. Mellinger pointed out, basically, they showed that competence is not achieved until 275 colonoscopies is performed. Whether that's really full of data enough to say that that's true, we do know that the more procedures you do, the better your efficiency is going to become and the better competent you're going to become, the more competent you're going to become. We do have Surgical Council for Residents Education, Fundamentals of Endoscopic Surgery. This is something that obviously is an educational platform for the residents. The important thing about the FES is that all of the residents now have to be FES certified to sit for the American Board of Surgery. So that's just an important point. I want to talk a little bit about endoscopic simulators. These are really good tools if you have them available. They're two main companies, GI Mentor 2 and AccuTouch Systems, and they really allow for individual training programs and personalized feedback. These current simulators, though, lack the degree of realism to provide training to achieve full competency or to be applicable in certification. This kind of just shows you what they look like. They allow you basically to do programs. But one of the things I like about them is it's a good way that is in a setting for the resident or trainee to have basically an opportunity to learn scope manipulation, general techniques, and go through modules so that they can actually become a little bit more proficient before they actually start working with a patient. What are some of the challenges to training residents and fellows? Well, we do know that training residents and fellows prolongs procedure times by up to 40%. Reduction in reimbursement at teaching centers causes financial strain, and time and financial burden may be lessened with appropriate use simulator-based training. And so, something to keep in mind, like for us, I know that at Northshore, if you look at some of the actual schedules, the procedures are every 30 minutes. So it's hard to actually have a trainee come in and be able to get through those cases and that case volume without giving them appropriate time. These are just some of the validated measure tools that they have out there between gauges, the Mayo Colonoscopy Skills Assessment Tool, and as we talked about, Fundamentals of Endoscopic Surgery. And then we've also talked about privileges a little bit, and I just talked about in 2018, the American Board of Surgery will require residents to complete a dedicated flexible endoscopy curriculum, includes a validated measure of knowledge and skill, and simulated environment in clinical practice. They have to be FES certified, like I said. And these are some additional areas for training for our trainees, whether they go to the SAGES website, SAGES University, ASGE website, and then there is an annual course, the MIS Fellows course. This year it's going to be at Northshore. Dr. Ujiki and Dr. Duncan are going to be co-chairing this. It's a really nice system or nice program because it actually gives a lot of didactic lectures along with hands-on, and it gives the fellows and residents opportunity to actually look at the product and understand how these products work, so it better suits them for when they're actually out there practicing. What are some ideas to get residents trained? So try to partner with a gastroenterologist. Find an expert gastroenterologist willing to train the surgical residents. Partner with a surgeon with expertise in flexible endoscopy. So it doesn't just have to be a gastroenterologist. It can be a surgeon depending on where you're located. Consider developing a rotation with GI or surgery to participate in consultative service and endoscopy. Have the residents or fellows see the consults, and it actually becomes a benefit not only from a didactic point of view, but it actually benefits the teaching service. So they get this cognitive training in endoscopy. And honestly, I actually would love to see our GI fellows rotate onto surgery. Let them spend a month in surgery while the surgical residents are spending a month in GI. I really think it's important that that goes both ways. And honestly, the big challenges are finding physicians interested in training residents and fellows in flexible endoscopy. Obviously, there are demands on a busy schedule. You have low volume centers. You have to compete with the gastroenterology fellows' time. And honestly, there are a lot of GI gastroenterologists out there who are concerned about competing with surgery for endoscopy cases. What did we do at WashU? Just to give you an idea of how we help train the surgical residents. We actually brought the residents to the simulator before the rotation started to teach them basics, endoscopy equipment, scope manipulation. The residents spent a month rotating on with a gastroenterologist. They were actually assigned to an endoscopy room. The attendings would change on a daily basis, so they always had a different attending they worked with. They were not competing with the GI fellows for cases because they basically were in a room where the GI fellows were in a different room or were doing inpatient work. Almost all the cases that they were seeing were outpatients. And actually, I think there's an advantage to that because typically they're not as sick, there's not as much acuity, and you can actually spend a little bit more time teaching the residents. I also worked closely with Dr. Brunt because he had reached out to me when I was there to help get more training time for the MIS fellows because they wanted more time in endoscopy. So we tried to find time during my block general GI time, and they would come and spend time with me so I could give them more training. What are we doing at Northshore? Same sort of thing. We're actually getting them into the simulation lab to actually work on one of the simulators, and then I actually will spend an hour of time with them at the start of their rotation, basically doing basics, scope manipulation, understanding the whole setup, basically between the processor, how to hook it up, how everything works, and then I'll walk them through kind of scope techniques and scope manipulation. They spend a month with our gastroenterologist, but they also rotate as they're doing that, doing the consultative service. So they're basically seeing consults and also scoping. So I think it actually benefits not only the GI service, but also benefits the surgical resident. There's no competition with the GI fellows because the GI fellows usually rotating off at a different site. And the nice thing about our GI attendings who have actually been doing the training, they've been winning teaching awards because of this. So this is a really good thing for them. So in conclusion, flexible endoscopy will continue to be a large part of surgical practice. I really believe it's important that we are collaborative in providing proper teaching for the general surgery residents. Properly trained surgeons in flexible endoscopy benefit the patients, benefit communities, and the hospitals. And we need to encourage more collaborative efforts between ASGE and SAGE's members to train flexible endoscopy to surgical residents. Thank you.